pieces of our service delivery system. It was one that our Board of Supervisors was very proud of, our agency was very proud of. And among the many, many strengths of the IHSS program has been its effectiveness in basically allowing people to stay in non-institutional settings in their own homes, even as their personal care needs are increasing. And that's great. And at exactly the same time, of course, because it was a program that was standing alone by itself, it wasn't able to draw on the resources of the larger health system. So it was sort of in a silo in isolation. And over the past year or more, a really major focus of the state administration, the governor's administration, has been to try to say, how do we turn our current healthcare system into something that really is integrated and meets all of the individual's needs in a coherent way, in a holistic way, so that we don't have a situation where people are turning to medical providers for care that's reimbursed based on the number of visits or the number of procedures, et cetera, and at the same time may not be able to get the level of supportive services that they need for safely living at home, which is where we want to be. So one of the things that the state's been doing over this past year is working with the federal government to get permission to say, let's try to bring together, in this first instance, both our Medicaid program and our Medicare programs in 8 demonstration counties, of which Los Angeles is one, for a 3-year demonstration to establish what we're very sure will be the fact that if someone is getting their care provided in a setting in which their insurer is responsible not just for their hospital care or their doctor's visits or any institutional care, but they're also responsible for the success of their at-home care, that what we expect to see is that in that context, there'll be more available to and more resources for the at-home care. And so what CalMediConnect does is, in the 8 counties and for up to 200,000 people in Los Angeles, the number is not capped in the other counties, but it is only in Los Angeles, is it allows those people, starting in the fall, to transition into a sort of a dual system in which both their Medicaid and their Medicare services are coming out of the same insurance plan. In the case of LA, people will have the choice between 2 plans, LA Cares or HealthNet. And those plans become responsible for helping work with individuals to have care plans that are holistic and that meet the services that the individual wants, bringing together their medical care, their social care, any behavioral health care, and home and community-based care, including the in-home psychology services program. So that was a long answer to a very simple question.
It certainly makes sense when you describe it, how the managed care plans will be, have the Medicaid dollars and the Medicare dollars, and the most expensive cost of them is the hospitalization, so they definitely have that incentive to keep people in their homes. What will be different about the IHSS program? A lot of our consumers are concerned about losing the independent provider mode or self-directed care.
Basically, nothing changes in the IHSS program as the consumer experiences it today. They still remain responsible for hiring, firing, managing the work of their provider. Their hours remain as they are to be assessed by the county social workers on a regular basis. The managed care plans can't reduce the hours. However, if the managed care plan identifies that there are additional needs that someone has that could be met through other parts of the health delivery system, then in this construction, the managed care plan, as you say, has the incentive now so as to help the person avoid the need for hospital care or other institutional care. They have the incentive to help bring other services to the person's home, assuming that the person wants that level of service. And so that's from the IHSS perspective, what the consumer's seeing is basically still the same program, with their same rights, in terms of supervising their caregiver, the same process for assessing their needs, their same rights for any sort of fair hearings or need to review things. So, in a sense, no change on the IHSS side.
That's good. And I noticed there's actually some improvements right off the top with some added things for IHSS. It's my understanding that there'll be things like vision, dental, and non-emergency transportation, which is things that they're currently not getting. What would you tell, the consumers? One of the things that we're so concerned about at PASC is getting the information to them so they can make a decision. One thing that we didn't talk about is that they will have to make a choice related to Medi-Cal, but there is the option to opt out on the Medicare side. But my thought is that, they should really look at this. Any recommendations for the consumers and where they can find information or what they should be looking for before they make their decision?
Well, there's going to be a lot of informational material going out starting in July, going to consumers. There will also be counselors who are going to be provided through the plans and through the rollout to help people make decisions. On the Medicare side, as you say, the individuals have the choice to opt out if they find that they're not satisfied with care. They have a transition period to retain their current providers so that there aren't abrupt changes in shifts. And on the Medicaid side, they can change their managed care plans as they see the need to do so. Obviously, the goal is to create a stable continuity of care for people, so we're not trying to sort of encourage experimenting backwards and forwards. The goal is to build continuity for the individual. But if it isn't working for an individual, it's also to be sure that they have choices, they have recourses. And in addition to having the same appeal rights on the IHSS side, the managed care plans have their own appeal systems to problem solve any individual problems people are having.
Yeah, and we hear the word continuity of care a lot and integration. And I'm not sure everybody knows what continuity of care means. Is there another way that you might explain that?
Well, the expectation is that most people will have a care coordination team that will include their medical providers, a care manager, with their agreement, their IHSS provider can be included in the team. And the intention is to have a care plan that addresses what are the various needs that an individual has and how to meet them as seamlessly as possible, how to be sure that as needs change, they are being met in a real-time basis, and that it's not sort of being left to an individual to have to guess at where to go next or how to access the next part, or to have to personally navigate between multiple providers whose systems may not be interconnected, information may not be shared. So the intention is to have a situation where the whole notion of health, including home and community-based care, is considered one agenda for each individual.
Excellent. We're telling everybody in Los Angeles that they can go to our website, pascla.org. Is there a general site that they can go to?
There is at the State Department of Healthcare Services has a site, which I don't actually have the address in front of me.
I think, I don't know for sure, but if anybody Googles
CalMedi Connect.
I think there's CalMedi Connect, and then there's CalDuals. I just can't remember if it's .org or .com, but you can always go to pascla.org, and we'll provide that information. And I'd like to thank Director Lightbourne for taking this time. We really appreciate you spelling this out in a simple format for our consumers. And
Good luck with the program.
Thank you. Thanks, Rick.
Thank you.